Manimaran. Over to Mr. Manimaran.
All right, so ladies and gentlemen, the last speaker for the scientific session 4, clinical documentation, improvement and patient experience is Mr. Manimaran, and he will be speaking on CDI in primary care. Over to you, sir.
Yeah, good evening to everyone. My innermost gratefulness to this MEDRECON 2020 and HERAI. HERAI continuously coordinating and supporting these conferences for almost 20 years without any break. I would like to deliver my talk about how the CDI implementation, how the CDI program was implemented in Primary Healthcare Corporation at Qatar. Say, clinical documentation is any manual or electronic notation made by physician related to patient condition or treatment. If the clinical documentation meets these 7 criteria, then the documentation is high quality clinical documentation and maintain the gold standard. The 7 criteria are legible, reliable, precise, consistent, complete, clear and timely. Legible is clear enough to read and easily deciphered. If you see this in the red mark, we cannot identify whether it is lab value or blood pressure value. And sometimes the doctor will write their own short forms and improper abbreviations. When documenting this can be avoided. When reliable is trustworthy, safe and yielding the same result when repeated. For example, the patient is admitted for acute shortness of breath, chest pain. The physician ordered Lasix, oxygen and theophylline, and he writes finally the diagnosis is acute exacerbation of COPD. Oxygen and theophylline is for acute exacerbation of COPD. Then why Lasix? Lasix is for congestive heart failure. If he writes this, then we can rely, we can trust. And the other criteria is precise. Record is accurate and strictly defined. Say example, the patient is admitted chest pain, shortness of breath, fever and cough. The doctor writes the diagnosis of pneumonia. But when the X-ray shows that more definitive diagnosis of aspiration pneumonia, if the record shows more definitive diagnosis, the doctor should write that more definitive diagnosis of aspiration pneumonia instead of pneumonia unspecified. And the next one is consistent. The record should not contradict itself. The attending doctor writes congestive heart failure, pulmonologist writes pneumonia. We don't know whether the patient is having congestive heart failure or pneumonia. It is the attending physician responsibility. He has to completely or clearly mention that the patient is having congestive heart failure, then the record is consistent. Complete is record has maximum content and thorough. The physician order comprehensive blood chemistry. The result shows less in sodium and low value in potassium. After that, there is no documentation about these test values. The doctor should write whether the patient is having hyponatremia or hypokalemia, or these values are clinically insignificant. Then only the record is complete. Clear. Most of the time the doctor writes symptoms like chest pain, knee pain, like that. They are not mentioning any diagnosis. Whether we don't know whether the chest pain is due to some cardiac problems or the symptom is etiology was undetermined. If the etiology was undetermined, the doctor should write that chest pain, etiology undetermined. Then only the record is giving the clarity. Timely. When the physician did not provide documentation immediately after caring for a patient, the quality of the documentation in the patient record was susceptible to neglect and data loss. These are all the 7 criteria. If the clinical documentation maintains, then it is that high quality clinical documentation and maintain the gold standard. Now just I would like to give you the overview about that Primary Healthcare Corporation. Qatar having 3 regions, northern, central and western. And we have 27 health centers, all the 3 regions. It may rise up to 30 by end of this year. All are having that outpatient visits only. Per day patients visit around 18,000. If you are taking only clinical visits, 14,000. The remaining 4,000 will be that lab visits and pharmacy visit investigation visits, etc. All the health centers having electronic health record system and connected via network. As per the Health Information Management and System Society, we are already attained stage 6, as Mr. Shenil told, and that is stage 6 CHR implementation, and now we are working on stage 7 transformation. Stage 7 is that highest level of transformation, not only the documentation image or discrete data, but also MRI scan images, X-ray images can be readily shared via electronic transaction across the country. Patient can access their record from home. No need to come to hospital and request the information. Up to this, we are already attained, and the other issues, our technical people are working on it. And our management committee wants to know whether we need that CDI program or not. For that, they are asking us to do that gap analysis. For doing the gap analysis, we are taking 55% of from top 20 diagnoses. Based on our disease registry, 55% of patient records or patient visits fall in the top 20 diagnoses. That is the maximum fall from the number 1. If you are taking that 100, that top 20, the 50% of patient visits are in the top 20 diagnoses. So we are taking that 50% from top 20 diagnoses, and the remaining 45 will be that other diagnosis. That is a representative sampling. And the findings we are submitted to that HIIM steering committee. The gap analysis findings are, we found lack of specificity of diagnosis. The doctor writes only diabetes mellitus, wound, trauma, or burn. They are not writing diabetes mellitus is type 1 or type 2, juvenile, and wound is, the location of wound is missing, and trauma, what trauma, burn, the degree of burn. So the specificity is missing, and treatment is not support the diagnosis. The doctor prescribes the medication, so that is a reliability issue. They are prescribing medication, but there is no documentation for that. And that clarity is also missing. They write that patients came for follow-up, patient came for refill medications. Why the follow-up? Why refill medications? It was missing. And medical necessity. They are ordering the investigations. Why it was ordering? That the information is missing. This is not all the record, but only few, but still it is there. And sometimes the doctor forgot to sign in the power chart, so we are unable to see in the electronic chart in this power chart, in the system. So we consider this is no notes. The doctor is not writing the notes. So these findings we are submitted to that our management committee, and management committee decides to initiate the program because there is a room to develop in the documentation. For that, they give this project to our HIM leads, Mr. Salvakumar Swami, Mr. Mujib, and Mr. Arbavi. And they define PHCC should be this minimum expected documentation should be there in each patient visit. And they form that CDI team, and they plan how to implement this CDI program and identify the focal group in each health centers. For that quality, minimum expected quality in PSSC, the notes should be in SO format, that is subjective, objective, assessment, and plan format. And each note must have that specificity and completeness. From the notes, we must understand what is the past and present problems, and the reason for ordering the test, and why the physician is sending the person to referral to other health center or other tertiary care. And when we read the record, we must know that why, in response to that patient's progress, in response to their treatment, so whether it is improved or not improved, all those things. And they form the CDI team as a blended model. As Mr. Sunil told that, we have that physician 2 number and CDI specialist 2 number. They are qualified and certified, and senior staff nurse and coding specialist 4 people. They are also completed their certifications. In the physician and the staff nurse, because of their clinical background, they can easily identify the gap in that clinical evidence and the documentation. And that CDI specialists and coding specialists are well versed in their coding knowledge, coding guidelines, and clinical documentation principles, and also their expertise in confidentiality, privacy, all those things very much useful when sharing the information. sorry. And they want to implement the CDI program in step by step, that is phase by phase. I already told that we have 27 health centers. It is very difficult to implement all the 27 health centers at a time, so they decide each region 2 health centers and totally 6 health centers at a time they wanted to implement this CDI program. The advantage of this method is focus on particular health center is more easy, and the initial measurement is more efficient and reliable. Studying the trend is easy, whether it is improved or not improved, and we can eliminate the risk of failure because if there is any hurdle, we can give more attention in that particular area. And with less staff, this method is effective because we have only 10 people in the CDI team. And they, with the support and strategic leadership of the executive director, a work group was formed by the HIIM lead, known as focal group, in each health center, helped to implement the program. Each health center, the focal group members are health center manager, physician lead, and CDI specialist, coding specialist. Each and everyone having some roles and responsibilities. It was defined by the HIIM leads. And they conduct the meeting with the focal group. In the meeting, they inform the standards of documentation at present in PSCC. What was the standard, where it was lacking, all those things are explained. And roles and responsibilities of each focal group was defined and mentioned in the meeting. And they elaborate the physician query process, who will be review the record, how it will come to that physician mailbox, and how they are going to reply, and what will be the final output, all those things. And they mentioned the time limit of completion will be that 72 hours. If the query comes to that physician mailbox, they have to reply within these 72 hours. And if the CDI program is going smoothly, what will be the expected outcome? All those things are explained in the meeting. And the physician query process, as already Mr. Sunil also told about this. Here we are, because that large volume of records, here the coders is reviewing the record. If they need any clarification, then they can send the query to the physician, and the physician response is as addendum in the power chart. Then coder will ensure that the deficiency was clarified or not. And each and every month, the CDI team members meet the focal group each month with the CDI metrics. That is, number of records are reviewed, how many queries are sent, how many responses, and what will be that improvement, what are the areas to give more attention to get improvement. All those things are discussed, and based on the decision, the following days it will be followed. When we are implementing this CDI program, what are all the problems we are facing during that time? Initially, the physician not welcome the program. They think that this is finding the fault for their activities. We explain them, actually we are trying to help you to identify where the documentation is lacking. And we inform them the documentation guidelines and principles, all those things. Then for us, it is very difficult to get involved the physician within this program because of their busy schedule and other thing. Then we make that rapport with the physician, and whenever the chances we get, we meet the physician and we discuss, then they slowly involving in this program. And that medical reconciliations, this is that real technical issues. Whenever the physician ordered some medications, it is not linked with the diagnosis. So these issues we escalated into the clinical information system people, and they update the software. And we feel, and the doctor finding that diagnosis and diagnosis codes in the power chart during the drop-down menu. So we provide the list of administrative codes and keywords to check the diagnosis. Now it is somewhat better. And the outcome is really amazing. The no progress notes reduced to less than 1%. Now they are signing. Even if it is missing, the next day we will send the notification to that physician. They immediately corrected and sent back to us. And specificity also increased 84%, and clarity increased 82%, reliability. So all the areas are increased. Now we are completed 6 health centers, and we are moving to that another 6 health centers. So totally at present 12 health centers are over. Remaining will be in the following days we will move. So along with this, my conclusion is a clinical documentation improvement program addresses the quality of the patient care, data capture, and outcome metrics, and stands to be an important factor within the healthcare facility. Thank you.
Thank you, Mr. Manimaran, for sharing your experience in implementing CDI program in Qatar. I just want to tell one thing about Manimaran. When I returned to India for some time, I wanted Manimaran to take over NMC from me, but he refused. And I was thinking why he is hesitating. Then only I came to know he had a plan already to go to Qatar. Okay.
Primary key. So we have all these three speakers and we have the chair with us. And now to felicitate the chair, can we have Mrs. Suma V. Madhavan,